All right, so now we can get into the fun part where all of y'all get to wake up from your food comas at lunch and participate in a conversation. So what stood out to you from the panelists that we just heard? Can the staff help me with the mics, please? What stood out to you from the conversation that we just had? What stood out to you? And if you want to say something, you can raise your hand and the staff will bring you a mic. Just remember to state your name, affiliation before you speak.
So can I exchange this as a question and answer session for the panel? So I can turn to the panel members where they are. So your question was what stood out?
Yeah, well, I want to know what did you think about it?
So I think that it's clear from experience, personal experience, or the collective experience of our group, as well as what we've heard here, that we'll continue to push on the EHR. But I was also struck by the ability of the current capabilities of apps on portable devices, our smartphones in particular, and there being an interest in collecting data that way and reaching out to individual patients. So I wonder if we could discuss, and full disclosure, I've been collaborating with Dr. Francis for about 5 years now on some of the transformative technology that Dr. Francis is working on. But I wonder if we could discuss parallel approaches in continuing to evolve the EHR to best serve the needs of preparedness and response, understanding that's, turning the big aircraft carrier, and developing that in parallel with the much more nimble and user-based capabilities of smartphones.
Okay. Thank you. There was a comment over here, and then we'll go here. Alexa's coming down with the mic. Just 1 second.
It's really, I think your question is perfect because I think one of the biggest, the biggest movement like in Africa in terms of the healthcare advance for them is the smartphone, because they have not the luxury of patient coming back in and being able to check them. So what happened is that they basically put everything on the smartphone in terms of sending information, doing the lab information, even to the point of screening patients who should get what. And so I think we should be able to do that in the United States. And of course, there will be hurdles in terms of the confidentiality, but I think it's getting more like, because now patients can provide diabetic, like blood glucose information. We have remote patient monitoring devices for chronic disease patients that want to sign up. So I think those information absolutely, I think Rhonda mentioned about exactly is that you can basically sign on to website and fill out information to get the MCM. And you can basically also like allow the doctors to access to your EMR and basically couple all those information together. And I think that will be the next generation. I also feel that like, because we deal with the young generation a lot, but even the generation that are older generation, they love the smartphone. I was in the elderly place and she was not using the smartphone because she needed to be really big. And you know what happened? She put her phone and connected to the monitor, the TV. So her phone was so big on the screen and she's checking her cholesterol level, and I was really shocked. So if you think about it, is that I think there's a lot of hope there, but it is not going to be evenly distributed. So, but my feeling is that we just have to march on to get those message out, and so that people will enroll in it voluntarily. Then we will have, like, we will start to build those network of knowledge and capability.
Thanks, Eva. You're so optimistic and enthusiastic about it. You make me think this can really happen. Yeah. So if if people are the best source of data for determining harm and benefit, or a more direct source of data for determining harm and benefit, how can we engage them and empower them to give us the data that we need? There was another comment or question here.
Yeah. Hi, Harlan Dolge with Biodefense Network. I was a little confused by this, which I guess I'm constantly in a state of confusion about a lot of things. But so this morning we were talking about data, and I think we have to define data, and I think it was Skip in the panel that said data means different things to different people, and maybe that's why I was confused. So this morning we were talking about data after an event. How can we determine how effective medicine has been after it's gone in the hands, who's taken it, how many people haven't taken it, that type of data. So the data at an event, medical countermeasures event, because we ask everybody to fill out a form, the data at the event is usually plentiful. It may be in paper format that has to be translated into electronic format. And then follow-up care data is plentiful. And then there's the data that's out there that's unknown that we have to figure out some way, maybe social media, because I do agree that that can play a part, of getting that data. So there's at least 3 types of data that we have to try and figure out during this session, I guess, how we can compile all of that data. And I think the data that wasn't really talked about at this session, unless I missed it, was that last piece that I think the FDA wants to capture, which is how do we deal with data we don't have yet? And how are we going to try and capture that? And there are ways. Social media is one. Polling is another. Reverse 911 system. I mean, those are the types of things we can maybe try and ferret through the next day or day and a half.
So what's an example that you would offer up to us? What's data that you want, or what's an example of what you're saying? How would you answer your own question?
So what was discussed this morning was for data that we don't have yet, it's you've handed out pills. Let's use pills as an example with like anthrax and pods. So how many people didn't come to the pods? I mean, we have no way of knowing who didn't come. Do we know, is there a way to figure out of the people that went away with medicine, how much, have they taken the medicine? Have they continued with the regimen? Then how many people felt sick from taking the medicine but didn't report it into a doctor? Those kinds of data points. I thought that's where this was going a little bit this morning.
Well, it can go in lots of different directions, so yeah. Other questions? What else stood out to you from there's a comment here and then one in the back and one over here. Oh, well, here is fine and then we can move around.
The theme of this panel was figuring out if an MCM offers harm or benefit, and when you mentioned collecting data directly from the impacted population, if we want to have effective data sets that influence behavior, we need to collect those in partnership with communities, and we can't swoop in the moment. We have to contextualize this risk with hazards that people face every day. In King County, people are much more likely to die of pneumonia, opioid overdose, domestic violence. And if we're not, as health professionals, demonstrating an awareness of and taking action on those risks, then we can't expect to partner with people in this type of an event.
Thank you. There were some questions or some responses here in the back.
Thank you. My name is Joel Simpson. I'm a pediatric emergency medicine physician here at Children's National and do a lot of the emergency preparedness work for Children's National. And I wanted to bring up a topic mainly because I'm here with a medical student from GW and a resident at Children's National, both of who are interested in disaster preparedness. And I started my medical school the year of 9/11 here in DC at GW. And still along my training, despite being medical director of disaster preparedness, have not had an internship, a course, guidance on where do you start to build the tools to use the ugly data that we're talking about. And we're swimming in data at Children's National in DC with 130,000 patients annually, and still have been struggling to figure out where are the mentors, where are the internships, where is there a list of things where we can actually develop the skills to use the data and produce the information that you guys are requesting.
I'm seeing lots of nods and yeses. There's another comment here.
Charles Cairns, University of Arizona. I just want to follow up on that comment. I think that, first of all, that was a great session. And the thing that I took home from it was the power of cloud computing. I think that all of these ways to kind of be above the system and integrate that on a live basis can be very powerful. But we need people to be trained in how to utilize those data. And one of the previous panelists talked about the challenge of analytics. not only is the analytics challenging, but being able to use the analysis in a way that's going to impact either care or performance or quality or development of new medical countermeasures is really going to be critical. So I think having educational and training programs is going to be a key component to how we utilize these systems most effectively.
So if we take a step back for just a second, when we started the session, we were talking about how the key question that I'm proposing we focus on for the remainder of today and for tomorrow is how is the countermeasure doing harm or benefit? So and related to that, we would want to know about the populations that received it, the guidance they were given, adherence, compliance, comorbidities, the timing, and like I said before, the who, what, when, where, why, and how of that the medical countermeasure was distributed. Are there any of the elements of that, the who, what, when, where, and how, that we have trouble answering right now? So, you know, if a medical countermeasure is distributed, do we know, is it possible for us to find data to answer who, what, when, where, and how for that? There's a question or comment here.
Hi, Ben Eloff from CDRH at FDA again. I already mentioned the what issue, being able to identify the specific medical product. But I wanted to get back to just a couple of foundational things, which shouldn't be new to anyone in this room. Carmen had mentioned the circle that we find ourselves in. And it's funny that the presentations, the panel just before lunch was one side of that circle, and this is now the other side of the circle. As someone who develops and uses these data sources for a living, what I find is too much emphasis is being placed on the data elements themselves. And our data elements are developed by those of us who either have or currently live in the ivory tower of research or at academic medical centers, where we say, oh, well, these elements are very necessary for the questions that I used in my very early trials, and because they're something that I use and those who trained with me use, they're very important to be defined in exactly this way, whereas someone else with more or less the same technology has a different way that they wanted to address those same questions. And what happens is our community physicians working on the front lines have 5, 10, 15 different ways to answer the same set of questions, and we end up with duplicates of data captured with unreliable quality, where we don't know where truth lies. And these are some of the basic foundational issues that affect not only MCM response, but our understanding of healthcare overall. We need to get away from that circle that was mentioned, the circle of, well, here's a bunch of data, what do you need? Well, I don't know. It needs to be, here's a question I have. Now let's see if the data exists. If the data doesn't exist, let's make it exist and get rid of all of the noise. Why is this element being collected? Well, because that guy told me to. It isn't good enough anymore.
Right, we have a comment down here.
I wanted to just go back to the competence question, because people were saying, where do people get trained in this particular area? Since it's critically important, thinking about it from the perspective of data science, there are many programs being developed now at both the undergraduate and the graduate level. Like many institutions, Columbia has a data science institute, has invested in it. I think for about 50 spots, we had 4,000 applicants for the master's program, so it can be it's a very hot and competitive field. And that's one type of thing when you're getting somebody who's a methodologist. But it's also very important, when I showed that diagram that had the unicorn in the middle, is having that person who has the expertise in, and who's not going to be the method developer, who's a pure data scientist, but who's going to have data science competencies, informatics competencies, along with that domain knowledge. Because I think that's what some people are asking for. They want the person that has both aspects of that. And so it's kind of, there are mechanisms in place more at the doctoral and the postdoctoral level than there are at other aspects, with people being able to augment existing training grants by asking for data science supplements. So I think there's no doubt there's the need for the workforce, and people are beginning to create it in different ways. I don't think there's a solid competency document that would say this would be critically important in the health domain, specifically in public health emergency domain. So I think some work on what informatics competencies, because there are competencies specifically for public health informatics, but I think taking some of the existing things and figuring out where some of those knowledge gaps are, and what can be done at more of an undergraduate level, what can be done at a graduate level. And I can tell you, this is an area where there is amazing online training. There are so many Coursera courses in data science that are, so I think there's any number of ways, because we want to think about, well, who are the people who are already in the field and need to advance their skills. And so something like a big Coursera course may work for them, but in other instances, we really need to work on the pipeline of individuals to get them into this particular area.
Go ahead.
So I think there's also, like, for those of you, if you are in the area and you're not planning to get another degree, you can also get NIH training grants. That I have some of the MDs that are assistant professor, and I train them, and it's perfect because they are domain expert and they get more knowledge in the analytics. Not so much that they're going to do day-to-day analysis, but at least they understand, if they work in this area, how do they actually understand the answers. But I want to respond to the comment that you mentioned about the data collection part. I think one of the beauty that I noticed is that as we analyze the data, we will be able to provide exactly the feedback about what are the data, or what type of data are important to collect. And that becomes really critical, because now we collect huge amount of data, but the more data you get, the more confusion you get in the model. So by analyzing even at the beginning, preliminarily, like just preliminarily looking at the data, you are able to really prioritize and screen what are the key elements. And that allows you to zoom in and really allocate your resources into how to collect valuable data. So I think that was a very good comment, because sometimes I think people always think the modeler give the solution to the end user and that's it. No, the answer is really, it is a feedback system, and it is a live system, because the model continues to change as new information comes in.
Thank you. There was another comment over here.
Yeah, I would just like to make a comment.
Can you
the data is actually being collected.
remember to state your name and
Raquel Bartz from Duke University. The data is being collected amongst these amongst health centers and very large networks. I mean, we're lucky here to have Charles from Banner Health, but I'm not sure my administration, there's been enough value add that we've articulated to why my administration should actually allow us to get the data out of the system. And, you know, so we get the data out of the system, we aggregate the data, we help the FDA, but ultimately there's a bunch of steps in between doing that and getting the data back to the administrators who actually want to know all of this information as well. I'm not sure and the clinician, I'm a critical care physician, I'm not sure we've really done a very good job of actually articulating that back to all of the health systems. Why should they give you their data?
Yeah, that's a great point. But also, there's another comment. Did someone have their? Oh, here.
Quite often, we end up with so much data because we can, and we collect the low-hanging fruit of data because it's easy. But the real data that we may need is much harder to find, and that becomes a challenge. Like Eva, we work in the field of operations research. So for many years, our field had many, many models and very little data. Now we have an overabundance of data, but it's not always the right data. And this challenges our ability to use the models. So analytics has become hot, as someone pointed out, but that doesn't solve the problem simply because there has to be a match between the problem to solve, the models, and the data. I'm going to give you a personal story. I work with the TSA on security issues, and I told them exactly the data I needed. They had it, and they couldn't give it to me, even though it would result in significantly more secure airport operations. So they have the data, but they couldn't give it to me. And they trust me, it's not a matter of it, but who got in the way? The lawyers. The lawyers prevented us from getting access to data and making the system more secure. And that problem pervades in every single area. It's not just in healthcare, it's not in security, it's everywhere. So I don't know if any of you are lawyers, nothing personal, but ultimately there are often obstacles which are tangential to the real focus, and we forget to realize that it's a systems issue, not a particular problem.
Thank you. So that gets us, as we go to wrap up this session, I want to hear a little bit more from folks about some of the what puts us or holds us in the place where we are. We've talked a little bit about how the data across, and health data isn't necessarily standardized. We've talked a little bit about how we haven't demonstrated the value added for integrating and sharing data, so perhaps that stands in our way. That we haven't necessarily defined the problem, so we don't know what data we need to answer the question. What else stands in our way? What else is holding us in this place with MCMs? And specifically to answering the question about the harm and the benefit.
Responses and medical countermeasure dispensing, because that's my area of expertise. I think one of the things that stands in the way of collecting data is we need to have a shift in the paradigm of that we will be collecting data electronically. I know in New York State we're really trying to move forward with that, and that's the expectation. And with that data, you have the ability to recall that information, have readily accessible information on the medical countermeasure that was dispensed, the lot number, NDC code. So should there be adverse events, you can actually follow up on that more readily. And I just really think it's just going to take some time to try to do a shift in the expectation of how data is collected. There's still a lot of training programs for medical countermeasure dispensing that are still very focused on forms and paper algorithms. And we sort of perpetuate that rather than trying to shift towards looking at electronic data collection. I won't get into how-tos because I think that's all over the place. But I think it's really important to have that data readily accessible, so if there is an adverse event or there is a complication with a medication, you can actually address that sooner rather than later with the recipient that received the medical countermeasure.
What else stands in our way? And these are the things that we need to grapple with. If we're ever going to change the system and do things in a different way, we have to grapple with some of this deeper, heavy stuff first. So what else stands in our way?
My name is Jessica Corrales. I'm with Cadence Group, and I think a major barrier that's often kind of elephant in the room for reasons is lack of political willpower. So something that I notice is that's a common complaint, especially when we're talking about data, because so many of us who work with data are very science-oriented and we tend to speak very factually. If you want data systems to function toward public health preparedness, you have to get political buy-in, because the money follows the politics and the form of the data collection systems follows the money. So I went to the mid-year meeting of APHA in 2011, and they were very, very excited about electronic health records and their potential for public health surveillance. And I raised the point that still hasn't really been, I mean, I don't know that a whole lot of progress has been made on it, is that these EHRs, they're not designed for public health surveillance, and they're not really even designed for clinical process flows. They're designed for billing. And that's where the money is. And you didn't, you know, if you talk to nurses and doctors who have been in the business for ages, they resisted EHRs until all of a sudden money came with the ACA to start implementing them, and then everybody was falling all over themselves to try to buy an EHR package. Meanwhile, all of these software developers were building EHRs according to the requirements of CMS. Said, how can we build a product that fulfills the legal requirements for EHRs that these healthcare providers are going to then buy so that they can get money for the ACA? And nobody built these EHRs with any public health functionality in mind. And I worked in HIV prevention, and we were always trying to get hospitals to use their health data for HIV testing, and a lot of times the systems that they had couldn't even be adapted for public health screening because it's not something that's traditionally done in an ER. So I think particularly those of us who work in data, we have to learn to speak the language of politics in order to sell the importance of public health preparedness to politicians who make the decisions on how these products, they make the decisions about the policies that influence the design of these products. And that's tough for those of us who work in, you know, who work in government, but it has to be done. Without political willpower, we're contorting ourselves to make do with what we have.
Thank you. All right, I'm going to ask the staff to hand out the cards for this section. So we've heard about several different types of barriers. We've heard about workforce capabilities, capacity. We've heard about the data infrastructure itself, standardization and interoperability. We've heard about some conceptual issues and barriers around knowing exactly what we're trying to accomplish. We've heard about political will and funding and power and resources. So I'm going to ask you to do, they're passing out pink pieces of paper, and on the piece of paper, write your name and affiliation. You should get used to that drill because we're going to do it 2 more times. And on the piece of paper, write down an action that you think that stakeholders in this room could take to address some of the barriers and help us better be able to monitor and assess MCMs in the future. So what can we do in the next year to improve MCM monitoring and assessment, and from the perception of stakeholders in this room? So I'm going to ask you to write that on your pink piece of paper. What could we do in the next year as stakeholders to improve MCM monitoring and assessment? Write it on the piece of paper, name, affiliation, and you can put it out on the blue sticky wall to your right as you exit. And we're going to have a 30-minute break, so everyone should be back in the room at 3:30. 30-minute break, back in the room at 3:30.